Our next speaker got up this morning in London, I believe, and has traveled a long way to come participate in this school. Dr. Vaidya has been a champion for intraoperative radiotherapy, and we thought that his additions to this meeting would be important. And tomorrow he will be debating Dr. Wazer, which should also be a very interesting and educational experience. So I'm going to turn the podium over to Dr. Vaidya. Thank you.
Thank you very much for this honor of coming and presenting here for the second or third time. Yeah, I did wake up at 4:30 about. It's my 18th hour, so all my cortisol is working now. So if I slip, please forgive me. That is a poem we used to read every day in our school, and it has got a deep meaning, but we probably don't have time to go through it. But it does tell us, and that work actually won him a Nobel Prize. So it is to let reason work out its way through the dreary desert, sand of dead habit, and which is an example of what Bob Cuskey just said. So I shall be talking on Target and Target B trial. So as this is not, some of these slides are a bit of repetition for this audience. Over the last 100 years, we have supposed to have seen a sea change in treatment of breast cancer. But was there a change? The whole breast was still being treated. Surgery was less radical, more localized, but radiotherapy until 1991-95 remained to the whole breast. So we have, over the last 15 to 20 years, have moved in terms of breast cancer from radical treatment to more individualized treatment. And that has happened in breast mastectomy, going to lumpectomy. Axillary surgery has gone to sentinel lymph node biopsy, and chemotherapy is getting more and more targeted. And all this has been driven by randomized evidence. And it is this that we have tried to create for radiotherapy, to move from whole breast radiotherapy to more individualized radiotherapy. And this has taken, it's been 19 years now since the time I've been involved. It required a conceptual leap of localized radiotherapy, a technological leap, and collaboration with industry to develop a new machine and safety randomized trials. So just the same way, I caught Bob Cuskey's talk just at the right time, because I came across a very similar experience. Back in 1992 in Tata Hospital, I had to tell patients, can you stay in Bombay for 6 weeks? If you can stay in Bombay, we can preserve your breast. If you cannot stay in Bombay, we have to do a mastectomy. And it was a standard teaching to all residents who came to Tata Hospital. And I was surprised when Michael Alvarado from UCSF told me that this is what he tells his patients, prompt him to say, and when he goes and sees patients in the county hospital across the bridge. They don't want to cross the bridge every day for 6 weeks, and they would prefer a mastectomy. They can't afford it either. So this was in the clinic what was happening. And in the lab, I was doing this whole organ analysis of mastectomy specimens to assess whether Indian patients had multicentric cancers. And in order to analyze them properly, I said, let us devise a way in which we analyze them in 3 dimensions. And this was new. I didn't know it was new. I thought this was the way it was supposed to be done. And I found that 2/3 of the breasts which I analyzed had cancers in the breast, in addition to the primary tumor. And these patients could have had lumpectomy. They were having mastectomy only because they couldn't have radiotherapy. And when you plot them in 3 dimensions, I found that they are all over the breast. So the first conclusion immediately was, everybody should have a mastectomy. But luckily, although breast cancer is frequently multicentric, as you all know, most recurrences occur around the tumor. Recurrences in other quadrants are at similar rate as other breast, despite the absence of radiotherapy from whatever we knew at that time. So it made sense to give radiotherapy only around the tumor. And this is when I came to Royal Marsden to meet Professor Baum, and we wrote a letter in the Lancet, just when this paper was being published on the BJC. And we were really called mad, really, in no simple terms. The hypothesis, therefore, was radiotherapy to the rest of the breast is not necessary in selected patients. So there were multiple concepts. Give radiotherapy only around the tumor, finish radiotherapy immediately after lumpectomy under the same anesthetic, and develop a new machine and an operation to do that. So it was an academic insight that led to the development of the new machine and the technique. And just by coincidence, a family friend of Professor Baum had a machine with which we could try and develop this. So we developed applicators of what shape they should be, and over a course of 1996 to 1998, we had a machine. So this was a spherical applicator which we could put in the tumor bed, and the first time it was done was a blank applicator, and the first case was done on 2nd of July 1998. I remember that night very well. So this is a 50 kV machine, and the dose that is delivered is not as high as conventionally thought, but it attenuates, and the dose distribution corresponds to the risk of recurrence. So it is 20 gray to the surface and goes down to 5 gray at 1 centimeter. That's the picture from the first case in 1998. And it takes about 20 to 25 minutes, and it is done in a standard operation theater. It's a technique which needs to be very meticulous, but it's relatively simple to learn and to teach. And the difference between this technique and the only other type of intraoperative radiotherapy that was started a few months after this from Professor Veronese's group is that this technique is done in a fresh tumor bed without any dissection, whereas the Elliott technique requires dissection of the skin and the deep tissues away from each other, bring the breast together in the center, and a metal plate is inserted between the breast tissue and the chest wall, and radiation is given from within. And maybe this causes deoxygenation for a short time, in the very time when the radiotherapy is given, which may make it less responsive to radiation, whereas this is fresh, intact tumor bed, which may make it more easily accessible. So we published quite a lot. And one interesting paper was the work from Aviano, in which we found that when you take tumor fluid, the fluid that collects in the wound in the first 24 hours, and put it on breast cancer cell lines, we find that it stimulates cancer cells, stimulates them to grow, move, and invade surrounding tissues. But if you take fluid from patients who have had TARGIT, it doesn't do it. Of course, we didn't know this before we started using TARGIT, but it was a very pleasant surprise. And we find that if you see this, if this video works, those are cells moving very happily in the fluid, bathing in normal tissue fluid, and not very happy when they're bathing in the fluid which has been taken from a wound which has been radiated. Because today, when we do surgery, we are very meticulous about margins. So what is radiotherapy doing? Is it treating the surrounding tissues? Normal radiotherapy even. So maybe that is why the effect on microenvironment is probably very important. And that is the reason for this may be the various cytokines that are changed by giving intraoperative radiotherapy with the fresh tumor bed. And because the skin is not radiated, it doesn't cause any harm in terms of wound healing. So phase 2 studies were between 1998 to 2000, and the large randomized trial was between 2000 and 2013. And the randomization was between risk-adapted radiotherapy and whole breast radiotherapy. The risk-adapted meant that everybody got intraoperative radiotherapy, but if they were found postoperatively to have high risk factors, external beam radiotherapy was supposed to be added. So it was a strategy, one strategy versus the other strategy, rather than a dogma of intraoperative versus whole breast. And we expected this to happen in about 15% of patients. It was in the calculations of power, and that is what actually happened finally. So this was the original trial design. Patient after biopsy, needle biopsy, would have randomization, surgery. In this group, about 20% needed to have external beam, but 80% had TARGIT alone. And the other group had external beam. When the Australian group joined, they found it logistically difficult to do this. So 2 or 3 years down the line, they said, we will choose patients better because we've had excision already. So we said, well, on one hand, we are losing out the idea of doing it in one step. On the other hand, we are getting better patient selection. So maybe that group will do better. So we allowed it because we had a pragmatic approach. And here, very little patients got external beam radiotherapy. So this was the time after 2,232 patients we published in The Lancet, where we found that at 4 years, the two groups were doing equally well. And we were supposed to stop at that time, but the way we decided, we had some sub-protocols, and we said, let the data mature, so we continued randomization, for good or for ill. And in 2011, the consensus session where at that time, the main big randomized trial was the TARGET trial, people felt that this could be used in selected patients. So this was a good, very surprising and pleasant surprise. So that is how the trial started. It was very slow in the beginning, and after we published, we continued randomization. And the trial closed last year in June to 3,451, one of the largest trials of its kind up to now. 33 centers in 11 countries, mainly in Europe, but also in Australia and USA. So one trial, 2 randomly allocated treatments, 11 countries, and 1.4 million data fields. So I had a lot of work to do with the statistician to analyze this properly. And this was presented in San Antonio, as many of you heard. The 2 groups were well matched. They were generally good prognosis patients. However, there was a large number of patients who were not so good prognosis. There were 500 about patients who were more than 2 centimeters or grade 3 or node positive. So we will have, over longer time, data on these patients as well. Now, follow-up has always been a point of discussion. When we talk about the whole trial, because we continued randomization, the median follow-up of the whole trial is 3.451, is 2.5 years. However, you should recognize that there are 1,222 patients in the trial who have a median follow-up of 5 years. And 1,222 is a number similar to the Elliott trial and larger than many other randomized trials. So we do have a large number of patients with long follow-up. And I'll show you why that shows up in our data. So we had 34 local recurrences and 88 deaths. So as you can see, local recurrences are fewer. Breast cancer deaths are fewer than non-breast cancer deaths. And the cause of death was assessed by an independent clinician who was blind to the randomization arm. We had stratification according to the timing of delivery of radiotherapy, and we had subgroups as per progesterone receptor status because of the previous finding in the Oxford overview, which had found that it looks as if sensitivity to hormone therapy predicts the response to radiation. And patients who are hormone sensitive appear to respond much better, and the proportional reduction by radiation appears to be much more. So the red bar would have been the radiotherapy recurrence without radiotherapy, and the pink bar, which goes so much more lower if they are hormone-sensitive tumors. So therefore, we felt the smaller dose and lesser extent of radiation with TARGET might do better with PGR-positive patients. And this was a predetermined analysis. So these are the primary outcomes which you have all seen. What was a pleasant surprise, again, was that we had fewer deaths in the TARGET group. Our non-inferiority margin was 2.5%, and overall, the difference was less than 2.5%, it was 2%. But we had a minus 1.14% of fewer deaths in the TARGET group. When you look at the original way of doing this, we had 2,298 patients, and there was no difference between the two groups in local recurrence, and the difference in deaths remained. So it was favoring TARGET. But when you looked at the post-pathology group, this is when wound is reopened at a median time of about 35 days or 37 days. So therefore, I can expect that there would be scarring, and this is probably the reason why we had a difference, which was more than 2.5%. It was 3.7% difference in local recurrence when you give it as a second procedure. The deaths were very few, so we didn't find a difference. So that is how it was done. If you look at this is pre-pathology, lump biopsy, within 1 week, surgery and lumpectomy. No difference in local recurrence. When you do lumpectomy 4 or 5 weeks, reopen the wound, and then give radiotherapy, we find 5.4% versus 1.7% at 5 years. So this is something that we have found new in this analysis, and this was a pre-specified strata, not subgroup analysis, and they had separate randomization tables. So this is a reliable result, at present at least. So we were cautious. We would not want to do post-pathology, and centers who were doing it have stopped doing it because of these data. The other thing we found also is that PGR-positive patients, there is no difference in local recurrence at all, and there is a benefit in terms of survival, whereas PGR-negative patients, there is a difference. There appears to be a large difference in PGR-negative patients. So what you have found is that all the small difference that we have seen, the 2%, is only in the delayed TARGET group or in progesterone receptor negative group. So that this large group of patients who had it at the time of lumpectomy and who were hormone receptor positive, we found absolutely no difference in local recurrence and a 3.1% difference in overall survival. Now, 3.1% in absolute terms is not dissimilar to the benefit from Herceptin. So although it is 3.1%, it is not a small amount when you multiply it with the number of patients who are treated. And this difference in death is not because of difference in breast cancer deaths. They were same. What it was a significant difference in non-breast cancer mortality. And this was 0.0086, halving of non-breast cancer deaths. And this was because of reduction in deaths from other cancers and cardiovascular causes. So this was a result, 0.47, p.0086. This was a surprising result, but that was because of a concept that we would have expected this much later. However, okay, there are 2 points I want to bring up now. Firstly is follow-up. This was a paper which changed practice from Veronesi from 1981, and he has very clearly said here, longest follow-up is 7.5 years, target is 12 years. It appears that longer follow-up will not introduce further changes because most recurrences occur within the first 3 years of treatment. And you can see that again in a more recent publication in 2012, that most recurrences occur in the first few years. So we now have more than 1,200 patients at this juncture who have these data. And most recently, the START trial result, you can see that at 5 years, the difference between the two groups is not dissimilar to the difference at 10 years. So I think we now have reliable data. And when you plot our data by analyzing the earliest patients, the medium patients, and the last patients, we get same results. So this is the cohort with the 2232 patients. This is the difference in local recurrence, that is 1%, and difference in death is 2.1% for the benefit of target, and that difference remains the same even if you analyze the earliest cohort, excluding the last 4 years of randomization. So it is a stable result with increasing median follow-up. If you take hormone-positive patients, then there is no difference in local recurrence and a 3.1% improvement in overall survival. And if you would like to see them in Kaplan-Meier curves, they are very, very similar for all those groups. Size matters. The HERA trial is 3451 patients. We had 3401. We had 3451 patients, as I've talked before. So now I think we have qualified what selected means. For selected patients, this we feel would be an adequate treatment. We should use it cautiously, as usual, any new treatment, fulfill eligibility criteria, and concurrent target at the time of lumpectomy in ERPR positive patients. And in about 1 in 5 patients, we would expect to add external beam radiotherapy. We found age doesn't matter. Younger age didn't make a difference. Grade 3 didn't matter. This is not dissimilar data from recent findings by Frank and Vicini. You have an app which you can download on either Android or iPhone, which was developed by my cousin, and you can tell you which patients should go to where. But interestingly, the original hypothesis that if you exclude radiotherapy, would patients have a problem? So if you look at only those patients who had only target, so they didn't receive external beam, analyzing only those patients, we had 803 patients. 80% of 63% of 803 is 405 should have had tumors in other parts of the breast. We had 7 recurrences in the scar, 6 in the other breast, and there were 405 foci of cancer in other parts, but we had 2 recurrences. So they don't grow, at least in this 2,077 women years of follow-up. So I think we have proven that hypothesis. The other question is the deaths. The cardiac toxicity can start very soon, as has been shown by Sarah Darby. Maybe it was masked in the old data because there was such a high mortality from breast cancer. And this is the data from Sarah Darby, which shows, and this has patients up to 2001, which has found that in the first 4 years, there's 16% increase per gray of dose received. And the Oxford overview of DCIS, this is something which Julia and I have been discussing. I would like to go through this. Do I have 2-3 minutes? Yeah. So this is the Oxford overview of DCIS, and they should have had something similar to what we found because they are good prognosis patients. Now, if you look at this is a group, 1878 EBRT was given, 1851 no EBRT was given. Invasive recurrences were 92 and 204, a difference of 112. Now, for every 4 recurrences, let us use the EBC-TCG formula, you should have had that many more deaths. You divide that by 4, you should have had 28 additional deaths in those who did not receive EBRT. But what happened in terms of absolute number of deaths? There were fewer deaths in patients who did not receive EBRT. EBRT given 186, no EBRT 167. And these patients, these trials did not prospectively allocate cause of death. So cause of death cannot be relied upon in these trials, allocation. So you should have had plus 28 deaths in the patients who received no EBRT, but we had minus 19. You add the two, you get 47 patients who should have had non-breast cancer deaths, more non-breast cancer deaths, which amounts to about 28% increase in non-breast cancer deaths. Now, this is a crude calculation, but we do not have any more data from these patients about their cause of death. But crudely, it seems to match what we have found. So the main results are that when you give concurrently with target, P is 0.31, there is no difference in local recurrence, there is no difference in breast cancer deaths, but there is a significant reduction in non-breast cancer mortality. I'll give 2 minutes on target boost. When we started, we gave target as a boost to tumor bed to assess its safety and how we can do it in the theater. And when we did the first 300 patients with long follow-up, hardly anybody was recurring. And what we found, and we know that in young patients, there is still a recurrence rate which is high, and maybe target is superior. And what we found when we analyzed this is that 5 years, and I use David Weiser's calculation on the web, which is available on the web, and I converted that into a macro and added each and every patient's expectancy of how many recurrences should occur. And we had half the recurrences what should have occurred using that model. And based on this, we have now got funding from Department of Health for £1.5 million to run a randomized trial, which we have now started randomizing. This is different from target A, is that eligibility is those younger than 45 or those over 45 who are at high risk and would not be suitable for target alone. Those patients are being randomized to receive intraoperative boost or external beam boost. And the trial is a superiority trial rather than a non-inferiority trial. And the trial has started recruitment, and we would welcome anybody wishing to participate. So I hope that we are going to we have probably moved into this, that patients who are more than 45 or 50, those who follow astro-suitable criteria, would be suitable to have target alone. And for others, we hope to randomize in target boost trial. And the last slide is about cost. And if you talk about cost, and if you see various interventions in breast cancer, in vertically, and the number of patients suitable, these are the patients diagnosed in UK. Those are the patients suitable for treatment with these drugs. That is the absolute reduction in mortality. That is the absolute number of lives saved per year. And that is the cost per life saved. So for Herceptin, for every life saved, it costs £1.2 million. For tamoxifen, £10, 10 years versus 5 years, it adds £4,200. With target versus EBRT, it costs minus £40,000. For screening mammography, it costs £500,000. For chemoprevention with SERMs, it's infinite because it doesn't save lives. So in perspective, you find that it is a cheap way of, it actually saves money while saving lives. I would like to acknowledge all the centers and all the patients who took part in the trials. And thank you very much for your attention.
Questions. I'd like to open the floor to questions other than the faculty members. To see if the people participating have any questions, please.
Hi, thanks for a terrific presentation. My name is Ross Halpern from Kelowna, British Columbia, Canada. And I'm curious, the target data, the reduction of non-breast cancer related deaths, if you stratified the patients by left and right breast cancer, I presume you should find one side had an obvious difference, the other no difference?
Yeah, now the point about left and right-sided, even in the overview, the ratio of right and left-sided is only 1.2. It's not completely on the left side. What happens mostly on the left side is when radiotherapy is given after mastectomy. But in the overview with Sarah Darby also, the ratio left and right death was only 1.2. So the effect is not too dissimilar on left and right. We didn't find a difference. There were 8 deaths from heart attacks. They were similar on both groups. So we would have expected it to be about 5 and 4 or 4 and 6.
Yeah.
So the numbers are too small to detect the difference. Yeah.
Thank you.
Just another question. I think the separation in the mortality curves is kind of peculiar because it separates at the beginning of about a year.
Yeah, 2 years.
And we kind of showed some data about the cardiovascular toxicity, but most of the deaths were not cardiovascular related, right? So do
They
you
were.
expect that secondary cancers are developing within a year?
No, the number of secondary cancers were not different between the two groups. They were about 35 and 37. But the deaths from secondary cancers were 8 and 16. The secondary cancers were more like lung or esophagus, which probably were the more fatal ones. And that's probably why we have found a difference early.
But they're developing secondary cancers within a year?
No. Their secondary cancers are 35 and 37. They are not different between the two groups. If the number of cancers are going to be different, that will start happening now onwards. So what we have found is the mortality from secondary cancers is halved. So because probably they developed in proximity to the breast, which is lung, esophagus, which are fatal cancers.
Any other questions? Do you have a question, Bob? Okay, we very much appreciate you coming. Tomorrow, as you know, we'll have a debate which will flesh out some more of the difficulties between partial breast and IRT and the struggle between the two on an academic level, as well as, and I warn you, having some fun with the presentations. Yes, right, in a collaborative way, that's correct. So we're going to take a break now, and we will see you back here shortly. I think we're pretty much on time with the schedule now, and I appreciate all the speakers in helping me do that. We'll see you shortly.